This program is brought to you by Emory University.
Good morning, everyone. It's a great pleasure for me to introduce today's speaker. I know we're doing something unusual and taking this slot, which is usually the Fellows Conference, but we have this opportunity to invite Dr. Prabhakaran, who is visiting after ACC, is visiting Emory. So we thought it would be a great opportunity for us to have him speak. And I assure you this will be a feast for those who are attending. Just by way of introduction, Prabhakar is a good friend and a colleague. He was educated in Bangalore Medical College in India, and then at All India Institute for Medical Sciences in Delhi. And then he did a master's in health research methodology, epidemiology at McMaster in Canada with Salim Yusuf's group, and is now considered an eminent cardiologist and epidemiologist and academician of global reputation. He's a distinguished professor of Public Health Foundation in India, PHFI, and has been instrumental in establishing 2 centers of excellence at PHFI. These are the Center of Chronic Conditions and Injuries and the Center for Digital Health. Before that, he built the Center for Chronic Disease Control, which is a bit like the CDC and is a leading research agency for chronic diseases in India. He is also founding director of Center for Control of Chronic Conditions at PHFI and has joint appointments in there as well as London School of Hygiene and Tropical Medicine and at All India Institute of Medical Sciences in Delhi. And also he has a professorship at Emory and has been a long-term collaborator with our global health department folks. He has published more than 600 publications, has an H-index of over 100, and is considered one of the topmost researchers of medicine in India. And in fact, has been cited as the 2% of the world's researchers by Stanford University recently. He's also a fellow of the Indian National Science Academy, which is the highest science academy in India, and has recently confirmed the Doctor of Science degree by University of Glasgow in Scotland. He's made exceptional contributions to science and medicine and public health, particularly preventive cardiology in low and middle income countries, and this is what he's going to be talking about this morning. And we have the pleasure of having him as a colleague, a friend, and has recently been, as we have all had received this Precision Cars PPG award from NHLBI, where we are going to phenotype for cardiovascular disease 20,000 people in India in 2 cities. He's a PI for the Delhi site, and the second site is Chennai. So this gives us the Emory researchers, fellows, trainees, faculty, a huge opportunity to study cardiovascular disease from inception to advanced stages in a very large population, almost 4 times the size of what Framingham was when it started. So with that introduction, I'd ask Prabhakar for thanking you for doing this, and please go ahead.
So good morning, everyone, and thank you, Professor Kayumi, for that very kind but long introduction. And it's a great pleasure and honor to always to be here as always. And I think this must be my 10th visit to Emory, but every time I come here, I learn new things, make new friends, and it's always a joy to see the vivaciousness of researchers at Emory. Now, I've titled this talk as Dynamics, Determinants, and Dimensions of Cardiovascular Disease Worldwide. And whenever we ask about cardiovascular diseases, be it cardiology residents, internists, or even public health researchers, people will say, you know, what if we look at the causes, they'll say that there are 3 determinants: smoking, physical activity, and diet, and 3 major risk factors: hypertension, diabetes, and lipids. So is that the whole story across the world? What are the differences? What are the similarities? What can we do about it? Is what I'm going to discuss today. And I'm going to start off with 3 case studies. The first is in Brazil, a city called Belo Horizonte, This is a person who is 25 years. He collapsed on the roadside while walking with a friend, sweating profusely and in excruciating pain. A fairly quick hospitalization and life-saving procedures, he survived a massive myocardial infarction involving the proximal LAD territory. He was born in a nearby town called Salinas. He was a school dropout, migrated at age 11 to Belo Horizonte to earn a living. He smoked cigarettes, increasing lately to 15 to 20 per day. He drank alcohol regularly and had a poor diet. There is no family history of diabetes or other heart diseases. The second case is a young CEO of a multinational bank in South Korea, age 42 years, non-smoker, a fitness freak, a marathon runner, and a healthy diet enthusiast, collapsed and died after a gym workout. Stress was cited as a major reason, but further investigation revealed also a consistent lack of sleep, averaging 4 to 5 hours a night for the previous few years. He had a lipid examination 1 year prior, and his LDL cholesterol was 220 milligrams per deciliter, which I think if you use the millimoles per liter, it will be something like 5.5. He was advised statins, but did not start them because of the fear of side effects and the general belief that statins are not very useful in healthy people like him, within quotes. Also, people told him that it was possible that relieving stress would take care of his lipids, as many people would like to believe. Our third case is Dr. M, a 55-year-old practicing cardiologist from Mumbai, who died in her sleep. She always consumed a healthy diet, had an excellent lifestyle, no history of diabetes, hypertension, and the lipids were within quotes normal. Autopsy revealed extensive triple vessel disease with total occlusion of proximal LAD. These may be three fictional cases, but let's reflect on these three case studies. What are the similarities that we notice here? All of them evidently had coronary artery disease, had a myocardial infarction. What are the differences? The latter two, the first two cases actually fit into our theory that these are risk factors, but the last one actually defies that logic. That cardiologists did not have any major risk factors. Indeed, when we look at worldwide, nearly 20 to 25% of people do not have any of risk factors that we talk of, though in the heart study said that 90% can be explained by simple risk factors. The next question that we need to ask is, are the reasons individual or societal? Is it genetically determined? Are there other environmental issues? Will socioeconomic status impact the future outcomes? And so there are several other questions that we need to think of when we reflect on these three cases. So I go back to Charles Dickens, who wrote the book, The Tale of Two Cities, in early 18th century, where he was comparing late 18th century, where he was comparing the French Revolution. It was written at the time of French Revolution. He was comparing the two cities, London and Paris. And he described the situation then, that it was the best of times and it was the worst of times. In fact, this is the opening line of the book. It was the age of wisdom. It was the age of foolishness. It was the epoch of belief. It was the epoch of incredulity. I won't read this. So you can see how the contrast was described by him in the book, The Tale of Two Cities. And when we think of the global cardiovascular disease, it's very similar to the Dickinsonian world. We have tremendous achievements both at population and individual levels. There's been a population level decline of cardiovascular mortality of more than 50% in high-income countries just in over one generation. There's decline in acute myocardial infarction mortality from around 30% to 4% in the 50 years time. In the 1960s, the mortality of due to acute myocardial infarction was close to 30%, but currently it's in-hospital mortality is 3 to 4% if people reach the hospital. There's a substantial decline in cardiovascular risk factors in these high-income countries. But when you look at low-middle-income countries, the prevention policies are uneven. There's huge disparities in care within and between countries, lack of simple and essential drugs in many parts of the world. In fact, simple drugs like beta blockers and statins are not available in many parts of the world. And there's huge gap between best practices and actual delivery. So I'm going to classify my talk into 4 heads. I'll discuss the burden in brief. We'll look at some of the causes, both at individual and population level. We'll look at some of the consequences and look at some potential remedies as to how to address this burgeoning problem of cardiovascular disease across the world. So when we think of cardiovascular disease, they're part of the non-communicable disease spectrum. And non-communicable diseases, according to the United Nations meeting in 2011 and 2015, they described it as the #1 public health challenge of the 21st century. In fact, to give a context, the UN General Assembly met on a health issue only twice. The first time was in 1993, I think, on HIV. And the second time was in 2011 and subsequently followed up by a meeting in 2015. Then, of course, the climate change has been added. So if you add this noxious mix of climate change and its consequences, it's quite devastating. And both are threats to economic growth and sustainable development. Originally, the WHO had what is called as a 4x4 paradigm, but it has shifted to 5x5. And I'll just, in a minute, let you know what these 5x5 are. So according to the WHO, there are 5 major non-communicable diseases, that is cardiovascular disease.
What's happened? So this
Cardiovascular diseases, cancer, respiratory diseases, diabetes, and mental health conditions, which are bound by 5 main risk factors: tobacco, unhealthy diet, physical inactivity, alcohol, and air pollution. And of course, there are others that include cirrhosis, kidney disease, and so on. But what the WHO has now added to this non-communicable disease mix is mental health condition and air pollution. Indeed, air pollution has emerged as one of the major risk factors for cardiovascular disease. And to put things in context, cardiovascular diseases constitute approximately 50% of all non-communicable diseases. So clearly, it's a huge problem across the world. So let's look at some numbers, and I promise that I will not talk about any more numbers after this. So cardiovascular disease is the leading cause of death globally. Annually, on an average, there are around 60 million, close to 60 million deaths. I'm saying 60 million because I think there were additional deaths due to COVID in the last 2 years. But these are data from 2019, which is suggested that the total number of deaths were around 58 million. Of these, 33% were due to cardiovascular disease, which is close to 20 million deaths. And when you look at the subclassification, ischemic heart disease was almost half of these cardiovascular deaths. Stroke was a third of these. And there were others such as heart failure, rheumatic heart disease, and others. But the most important point that I want to make is 75% of these cardiovascular deaths were in low middle income countries, and the distribution was equal between men and women, because there's a lot of belief that women do not get cardiovascular disease. Indeed, even amongst women, cardiovascular diseases are the leading cause of death. In terms of number of people living with cardiovascular diseases, it's more than 500 million. More than 500 million people in the world live with cardiovascular diseases. And another index of measurement is what we call as disability adjusted life years. It's a measure of how many years people lived with disability. For example, if the life expectancy is 75 years and a person developed a heart attack and went on to develop heart failure at 55 years, that person developed the disease 20 years earlier. But let's say the person died at 65 years. So there's a premature mortality. The person died 10 years earlier and lived with disability for 10 years. It's a composite of these two. So when we use that metric, there are close to 394 million dailies lost, which is 14% of the global burden. So cardiovascular disease, again, is the leading cause of daily loss in the world. So much so, Dr. Salim Yusuf wrote an article in Lancet in 2015. He said, because cardiovascular disease affects a third of adults in the world, it's the largest epidemic. I have heard a pandemic with emphasis here because it is a global pandemic ever known to mankind. What are the features of cardiovascular diseases in the last 3 decades? Ischemic heart disease or coronary artery disease is the #1 cause of mortality and disability. It has gone up from #3 in the 1990s. Stroke is #2. It was #5 in 1990. And is the third cause of disability. 2/3 of the stroke are ischemic and 1/3 of the stroke are hemorrhagic. It has high premature mortality in low middle income countries, high age specific mortality, and huge productivity loss because people die at younger ages. So when we look at age-adjusted mortality, it's Eastern Europe and Central Asia, which have almost 2.5 times higher mortality than high-income countries. And there's a graded relationship. The high-income countries have the lowest. And the top three in terms of age-adjusted mortality are East European countries and Central Asian countries, followed by Middle East and North Africa, and the third is South Asia. But when you look at it in terms of numbers, obviously it will be China and India, and the United States is number 4 in the world. So the top 5 countries are listed here. But there are huge macroeconomic losses. I'm just giving the data for India here. So the Harvard School of Public Health and the World Economic Forum estimated what could be the macroeconomic costs of cardiovascular diseases. So they looked at 2 things. What is the cost due to lost productivity because people are dying at younger ages? And what are the healthcare costs? And annually in 2015, it costed something like $906 billion. And by the time we reach 2030, it will add an additional $146 billion. India alone was expected to lose $2.17 trillion by 2030 due to cardiovascular disease. Just to give you the context of the GDP of India, the government of India is striving to make India a $5 trillion economy by 2025. And we are talking about a loss of $2.17 trillion by 2030. Worldwide, there's a loss of $35 trillion from expected loss of $35 trillion from 2005 to 2030 due to diabetes, heart disease, breast cancer, and chronic obstructive lung disease. So huge economic losses. Not only is there a macroeconomic loss, there is also microeconomic consequences of cardiovascular disease. We conducted this study in 4 countries, Argentina, China, India, and Tanzania in 2007, and looked at what is the catastrophic health spending due to heart attacks and strokes, and what is distress financing, that is people borrowing from money lenders, from banks, washing out their savings completely and so on, and found that India, China, and Tanzania had the highest. As the country was less developed, lesser insurance, lesser social security, the chances of going through a catastrophic health spending was higher. People were pushed into poverty. The only country which defied this expectation was Argentina, because they had a program of free care for people with acute myocardial infarction. We repeated the study 10 years later in Kerala. It showed a decline in all parameters due to government-supported insurance, which suggests that there is requirement for a social security spending to prevent people getting into financial distress and providing them financial protection from catastrophic illnesses. The predictors of these microeconomic consequences was when people develop MI at young age, people living in rural areas, low levels of education, absence of insurance, and lowest income education groups. So we also need a new thinking in terms of identifying cardiovascular risk. Our paradigm has always been to look at an etiological or degenerative or adult life model. That is, we screen people above the age of 20 or 30 years and say, okay, does this person have hypertension, diabetes, or lipids, and we should treat them, we should provide them lifestyle advice and so on. But there's an alternate model where early life influences, lower birth weight at birth, lower weight at birth, fetal undernutrition, maternal malnutrition, low undernutrition during the first 2 years of life, childhood obesity, all of which have a huge bearing on increasing the risk of cardiovascular disease as adults. So clearly, what we require is a life course model, because you really need a life course approach, essentially because there's accumulation of risk and the longitudinal risk accumulation across the lifespan, from both biological and social factors. So essentially what we are that we are programmed individuals due to fetal programming, genetic or epigenetic changes, and early life determinants. And added to this, environmental triggers, smoking, air pollution, bad diet, low physical activity will directly cause cardiovascular disease, either as an acute myocardial infarction, manifesting as sudden death, or chronic coronary artery disease, ultimately resulting in heart failure. Or the second pathway could be that they can develop an intermediate phenotype with metabolic abnormalities, which again increases the risk of cardiovascular disease. But as cardiologists, we know what the importance of a caudal view in our angiograms are. what happens to people after they develop cardiovascular disease and how do they die is conditioned by biology, personal belief. We saw that young man from Korea who died at 42 years because he possibly had familial hypercholesterolemia, but didn't take statins because he felt that it's not required. So personal beliefs play a major role in people who die due to cardiovascular disease, the life course, socioeconomic status issues, air pollution, other issues, and finally the health system response. So if I have to summarize, the burden of cardiovascular disease has reached epidemic proportions worldwide and is the leading cause of this burden. The lower middle income countries face majority of this burden, and majority of deaths in LMICs occur at younger age groups, that is less than 70 years, and cardiovascular disease has devastating consequences on the poor. So coming to the causes of CVD, do we really know the causes of cardiovascular disease? Let's look at their determinants and risk factors and their dynamics. In terms of determinants, I think these are the major determinants of cardiovascular disease when you look at it at a macro level or an upstream level. Demographic shifting, aging populations across the world, urbanization and industrialization, which determine the living habits, globalization, marketing policies, for example. Brazil grows fruits and vegetables, which are very healthy, and exports them to US. And what does it import in return from the US is chips and sugar sweetened beverages. So globalization, marketing also play a major role. Education and culture, beliefs, poverty, which determines the access to healthcare, built environment, which is a barrier or an enabler, and several vectors, which we already know, that is tobacco, unhealthy food, alcohol, sedentariness, and air pollution. All of these determine the occurrence of cardiovascular diseases. And in terms of risk factors, we all know this, and I will not dwell too much into this, modifiable, non-modifiable. But what we do not know too much is about the conditioning factors such as poverty, education, stress, life course, socioeconomic status, and fetal programming. But recently to this mix has been added the environmental pollutants, which includes air pollution, noise pollution, lack of green spaces, water pollution that includes heavy metals such as arsenic and lead, organic pollutants, and other social determinants. And a lot of work is needed to be done in this. The seminal interheart study conducted by Professor Salim Yusuf in 2000, in the early part of this century, showed that 9 simple factors can explain most of the population attributable risk. By population attributable risk, what do I mean? If I have a magic wand today and I just eliminate all of these risk factors or facilitate the good ones, I can eliminate 90% of the coronary artery disease risk. And so this, we could say that risk factor burden determines cardiovascular death, and said, yeah, this is what we should do. But we had the pure results. The pure study is a cohort study, multiple cohort studies across cohort studies at multiple locations across the world, having more than 200,000 individuals, and I think over 50 countries. So we saw the pure results, and I'll show you just what the pure results showed. So when we look at the risk factor burden, which they measured by what is called as a mean interheart score, it's a composite of the risk factor burden like hypertension, diabetes, lipids, consumption of fruits and vegetables, etc., etc. When you look at that, high-income countries have a high risk factor burden, both in urban and rural areas. And this graph clearly shows that low-income countries have almost less than 2/3 of the interheart risk score as compared to high-income countries. But when we look at mortality, it's the reverse. Higher mortality due to major cardiovascular disease, higher mortality to total cardiovascular disease, higher mortality to fatal cardiovascular disease, and death from any other cause, clearly indicating that there is a dissonance between the presence of risk factors and death in low-income countries. And there are multiple reasons for this. So we need to explain this paradox. And I'm going to evoke the epidemiological transition, which I'll explain in brief. There may be ethnic variations, for example, high propensity for diabetes among South Asians, lower socioeconomic status, new risk factors such as air pollution. Air pollution, for example, among the top 15 cities in terms of air pollution, nearly 8 or 9 are in India. And we are way above the WHO standards of 5 microgram per cubic meter of PM 2.5. The average for Delhi last year was close to 90. So clearly we have huge burden of air pollution. And there are variations in the health systems which determines the risk of cardiovascular disease. Now, what is epidemiological transition? Epidemiological transition refers to a change in the pattern of disease in a country away from infectious disease towards degenerative diseases. This theory was originally proposed in 1971 by Omron. It focuses on the complex change in patterns of health and disease and on the interactions between these patterns and their demographic, economic, and sociological determinants and consequences. Let me explain this a bit further. Man has undergone two transitions. The first transition was when man, who was a hunter-gatherer, became an agriculturist. Becoming an agriculturist and settling down as families, as tribes, resulted in contact with the soil, which was full of microbes and infectious organisms. And so infectious diseases became the major cause, resulting in major pestilence and famines. You must have heard about the biblical plague, the choleras and the plagues in the 13th, 14th centuries. So that was the first transition. The second transition occurred during Industrial Revolution. So much so when you look at epidemiological transition, there are 4 stages according to Omron. The first is the age of pestilence and famine, the epidemics of typhus, the epidemics of plague, the epidemics of cholera, and so on. The second one was the receding pandemics just around the time of the Industrial Revolution. And following the Industrial Revolution, there were these degenerative and man-made disease or lifestyle disease, as we like to call them. And when good policies are implemented, when access to care improves, when drugs are available, we get into the stage of delayed degenerative diseases. Now, Tom Gaziano and Salim Yusuf like to add another stage called stage 5, where there's a reversal of benefit. Like, for example, the obesity epidemic currently underway in the United States is reversing some of the gains that we have had in terms of cardiovascular diseases. Or the social upheaval in the former Soviet Union, actually, while the worldwide, where there was a decline in mortality across all ages except in sub-Saharan Africa, Russia was an exception, and the mortality increased because of the increased smoking, increased alcoholism, particularly because of the social changes that happened in the early 90s. And wars actually can make a big change in terms of this epidemiological transition. The process in terms of this transition is a country moves from a less developed country to a developed country, from an agrarian economy to an industrial economy, from a pre-modern to a modern economy, and from a primitive form of healthcare to modern healthcare. So what happens to cardiovascular diseases in these various stages of transition? In stage 1, the life expectancy is around 35 years. This is what US was in the 1900s, where the dominant diseases were infectious and nutritional cardiovascular diseases, a very low contribution from cardiovascular disease, and the major diseases was rheumatic heart disease and nutritional heart disease, and it affects the higher socioeconomic class. So there is actually a transition from higher socioeconomic class to lower socioeconomic classes. Now, when you look at obesity epidemic in the United States, it's a poor, it's a rural populations, it is the less educated, it is the visible minorities who have higher obesity. And as we move from stage 1 to stage 4, we have an increase in life expectancy, and there is a reversal, and cardiovascular mortality comes down to less than 50%. And cardiovascular disease comprises of coronary artery disease and stroke, which is largely a thrombotic stroke. In the early stages of transition, it's largely a hemorrhagic stroke. So if you go to Africa, for example, there will be a higher proportion of hemorrhagic stroke, rheumatic heart disease, and nutritional heart disease, such as cardiomyopathies. So this pattern is seen worldwide without exception. Maybe there may be some exceptions like Japan and Sri Lanka, where there have been different patterns, but overall, worldwide, you see this pattern in terms of cardiovascular diseases. The second thing is, between high income and low income countries, low middle income countries such as India, the time frame of health transition has been long. So the countries had time to respond. In the US, it took 200 years from the time of stage 1 to reach to stage 3, whereas in India, it has taken just 50 years. So there is a huge double burden of disease because the pre-transitional disease, such as nutritional and infectious disease, is huge in India. So there's a big double burden there. And one of the things that we are spoken about is urbanization, which is very necessary. But the way it happens is very different. It's chaotic in low-income countries, and that is an important reason. And the resources are limited in low middle-income countries. So the task before us as cardiologists is to prevent this transition. We have to telescope the transition from early stages to stage 4 rather than going through all these stages. And how do we do that is the question. So far, we know what the societal causes are, what the individual causes are. As the German philosopher von Goethe said, knowing is not enough, we must apply. Willing is not enough, we must do. And what should we do? I think there are two things that we should do. One is reverting to the normality. So understand the pivotal role of prevention and preventing recurrence of events. And prevention of cardiovascular disease at an individual level comprises of preventing people from getting exposed to the hazards of social pressure to smoke, for example, reduce the risk factor exposure, decrease the manifest CVD, decrease recurrent events, ultimately leading to recovery, and finally postponing the death or end-stage heart disease. And for this, we all know this is a very, very standard thing that we know have to go through these three things: primordial prevention, primary prevention, and secondary prevention. But most important is this needs to be across the lifespan. In the last 50 years, we have learned something about prevention, and the core prevention of principles of cardiovascular disease is the principle of the continuous risk, principle of population-wide risk, multiplicative risk, and absolute risk. And let me explain this in brief. When we talk about continuous risk, we're talking about risk of disease that changes continuously over the entire range of risk factors. For example, we are adept at looking things in a dichotomous way. We talk about hypertensive populations and non-hypertensive population. We talk about blood pressure more than 140/90 as hypertension, but 139 by 88 as normotension or not a hypertension. Now we call it high blood pressure. But when you look at things, it's even within the so-called normal range, between 120 and 140, there's a huge difference. There's the CVD mortality or stroke increases as we are closer to the higher blood pressure levels of 135 or 140. So there is no clear specific threshold for any of them, and this has been shown for all the risk factors. This is an example from the Framingham Heart Study, I think, where when you look at the systolic blood pressure from the lowest level of less than 112/71 to the highest level of 142/92 or 151/98, which is not very, very high, you will see that there's a threefold increase in mortality, even within this lower levels of blood pressure. So there is a continuous graded relationship for risk factors. The second is, as we want to believe, we think that most of the people who die are people who have highly elevated levels of risk factors, which is true. The large proportional deaths will be higher amongst these people who have high levels of risk factors, like let's say blood pressure of 180/100. The chance of that person dying is higher. But when you look at a population level, a large majority of the deaths will occur in the middle of the distribution. That is where the blood pressure is between 130 to 150 millimeters systolic. So we need to focus on this population too. The third is what we call as a multiplicative risk. And here are two examples of two groups of people. In group A, we have serum cholesterol above 245 milligrams, 245 plus milligrams percent. In terms of millimoles, it will be more than 6. Systolic blood pressure of 118 to 124, and a person is a non-smoker. Whereas in the second, the serum cholesterol is average, systolic blood pressure is a little high, the person is a smoker. And these are data from multiple studies. The risk of coronary artery disease, you won't believe, is 5 times higher in group B, though the person was not reaching the thresholds. This was done at that time when people who treat cholesterol less than 240 as normal. So at that particular point of time, when things were normal, just one additional risk factor of smoking increased the risk 5 times. So there is a multiplicative risk here. And finally, there's an absolute risk for each individual. It's essentially a combination of continuous and multiplicative risk. The absolute risk for a major cardiovascular event is dependent on the overall risk profile contributed by coexistent risk factors operating in a continuum. So to summarize, risk factors operates in a continuous manner and not across arbitrary thresholds. Most adverse events arise in people in the mid-range of a risk factor distribution. When multiple risk factors coexist, the overall risk is multiplicative. And in all populations, majority of cardiovascular events arise in persons with modest elevation of many risk factors rather than in individuals with a higher level of a single risk factor. So in terms of CVD prevention, what should we do? Should it be population based or should it be high risk? So when it is population based, it addresses the bulk of distribution through small shifts. You shift the curve, like blood pressure curve, by say 2 millimeters, the reduction in the population can result in huge change. But you also need to address the high risk in the population, that is individuals with the highest absolute risk of a cardiovascular event. So the question here is, can polypill, which is a combination of few evidence-based simple drugs across both these groups, can it help? And that's a question which has been asked several times across from the time when this paper was published by Richard Smith, the former editor of British Medical Journal. It was like the Gulliver's Travels, where the Lilliputians were looking at Gulliver's with an awe. Similarly, we were looking at polypill, which was theoretically touted to prevent 80% of myocardial infarctions. So why is polypill such an attractive proposition? Because it provides comprehensive risk factor control. We are treating several risk factors simultaneously, regardless of level and without screening for them. It can be population-wide intervention for all at increased risk, regardless of risk level, that is everyone above the age of 55 years and people at any age with existing cardiovascular disease. It has high efficacy. It prevents half of cardiovascular disease safely and at low cost. And there was a projected avoidance of 2 to 3 million cardiovascular deaths each year, and 2 to 3 times those for total cardiovascular disease avoided, and no screening or monitoring was required, and it was cost effective. This is the theory. But the evidence was difficult to come by, and only last year we have had multiple sources of evidence in terms of primary prevention, the poly-Iran study, the individual patient meta-analysis that we did in collaboration and looking at the HOPE-3, poly-Iran and several other trials, and another trial where we looked at both secondary prevention and primary prevention, and all of which showed that it was beneficial. And therefore, the question is whether we should move in terms of polypill, and whether it's a philosophical question which we need to ask. Many people would be against saying that we are medicalizing the population. If instead of asking people to smoke, we are going to give them polypill. But the fact is, it can reduce cardiovascular diseases. The second is secondary prevention. How do we prevent the recurrence of a heart attack? And what do we know? Secondary prevention includes simple drugs and rehabilitation. Simple 4 drugs: statins, beta blockers, ACE inhibitors, and aspirin. And lifestyle changes: tobacco cessation, dietary modification, physical activity, and stress reduction. But when we look at the treatment cascade for patients with known cardiovascular disease, we expect an estimated efficacy of 75% or so. But the real efficacy is down to 21% due to a variety of reasons, including patients accessing healthcare, interventions prescribed by healthcare professionals, and patient adherence. We did the Umpire trial, which is again a polypill trial, to look at the effect of fixed dose combination on adherence of risk factors, and effects on primary outcomes at the end of the study showed that adherence improved by 33% when we gave them polypill, even in the setting of secondary prevention. So clearly there is a role for polypill in secondary prevention. But the scale of the polypill needs the buy-in of medical professionals for risk, because risk factors has a continuum, and any reduction is beneficial. But there are people who talk about autonomy issues, prescription and dose titration. In terms of patients, there's acceptance of non-physician. They do not accept non-physician health workers, and positioning of lifestyle interventions in when we give polypill is an important issue. The biggest bottleneck is the pharmaceutical industries, where pharmaceutical industries are have actually decided not to manufacture polypill because it's not economically viable for them, because these are off-patent drugs, these are inexpensive, and actually prevents them from promoting new drugs which have slightly incremental benefit over these drugs. And again, we have governments and international agencies like WHO, which have issues in terms of approving these drugs. So this is about polypill, but what are the emerging themes in cardiovascular disease? There are new and emerging risks in terms of lipid markers. We had this American College of Cardiology meeting where we spoke about apolipoprotein B, lipoprotein little a, small length LDL, and several others. We need to think of the role of environmental pollutants. In terms of diabetes, we now know there are different underlying mechanisms. So in the future, we may have a new classification of diabetes that includes type 2A and type 2B, where we look at insulin resistance and insulin insufficiency as separate mechanisms. The role of emerging infections, we saw that in the COVID pandemic. We spoke about polypill. We need to look at family-based interventions. I'll talk about that a little briefly. We need to look at the role of technology and task shifting, telehealth, and implementation science. And in terms of research, we need to look at new methods of research that includes participatory and embedded research, emphasis of wellness over illness, focus on health systems and new research methods, and technology-based clinical trials. I'm going to give you an example of a family-based cardiovascular risk reduction intervention in individuals with a family history of premature coronary artery disease. All of us know in a given milieu or given environment, it is difficult for one individual to change the lifestyle when the whole family is having a different lifestyle. So here we recruited individuals who had an MI and identified their families and selected control families without a myocardial infarction and did a randomized control trial where we introduced a set of interventions that included screening for cardiovascular risk factors in these families, structured lifestyle intervention, and linkage to primary healthcare facility, and active follow-up for adherence. And in terms of achievement of primary outcome, we wanted that any of these 3 of the 4 should be obtained at the end of the study, that the blood pressure should be lower than 140/90, fasting blood sugar less than 100, LDL cholesterol less than 100, and abstinence from tobacco use. And what we noticed was that as compared to the control population, which had achieved primary outcome to the tune of around 40% of the individuals studied, it was almost 1.5 times higher. That is, there's a 60% higher, 2.2 times higher reduction in the primary outcome. So this was a great example of how we provide an enabling environment in the family or in the community to show that cardiovascular risk factors can be controlled better. And we are working, Dr. Kayumi alluded to this precision cars, where we are moving the needle from disease to health, and we are looking at precision medicine and precision health in terms of identifying people with high risk very early on in the natural history of the disease. And this is a large study over a 5-year period. We are going to look at multiple things, including imaging, omics, air pollution, and wearable devices. And we will get to know many other things. In terms of innovations in care, technology has a major role for surveillance, for screening and diagnosis, management that includes electronic decision support system and telehealth, and several others, including geographical information system, massive capacity building using online platforms, nanotechnology, drug distribution, and clinical trials. I'm not going to talk about all of these due to paucity of time. I'm just going to briefly touch upon telehealth and how to improve quality of care. For the last 15 years, that includes our partners from Emory, we have done multiple studies across India in multiple settings that includes the community, the primary care, the secondary care, tertiary care, and for various diseases, including diabetes, hypertension, coronary artery disease, acute myocardial infarction, a combination of diabetes and depression, using several principles, using a principle of providing electronic decision support system, which actually provides personalized advice with regard to an individual patient, integrated care, quality improvement program, cardiac rehabilitation using yoga, team-based care, and using management principles. And we showed that across many of these settings that we can actually control risk factors much better than the usual care. And we are in the process of trying to scale this up all across India. My colleague Nikhil Tandon and Shivani Patel here at Emory are working on a program called iTrek, where there's a pilot demonstration of how it can be done across the country. And we are moving in terms of developing electronic decision support system for several other diseases, because what happens during pregnancy and to the mother actually has a huge bearing on the child. And therefore, we are looking at gestational diabetes, pregnancy-induced hypertension, multimorbidity, and several other conditions. And what we have done now is to improve access. We have created interoperable platform with multiple technologies that includes the electronic decision support system, point of care device, which can do multiple tests, AI-enabled ECG called CardioScreen, a high-definition camera, and an electronic stethoscope. And we are delivering this in designated telemedicine centers. This is called an assisted telemedicine program, where a community health worker or a nurse actually talks to the patient, examines the patient we have provided training to them, and connects them to a doctor. But we also provide on-foot telemedicine assistance, where these individuals go to the houses where patients cannot come to the hospital. And we are working on a program where we can provide it to remote areas on a van. And this is how the platform looks like. So it has features of general physical examination, which is captured by the healthcare worker, a template-based history, vitals of visits with trends, lab results with trends, ECG readings, electronic clinical decision support system, and then a personalized management plan for these individuals, e-prescription. And we actually now connected them to an e-pharmacy, where the drug is delivered to the patient's houses, and there's a markup for follow-up visit and markup for referrals. And in fact, a doctor sitting remotely thousands of kilometers away can hear cardiac sound or a respiratory sound and follow up this patient on a regular basis. So this has got a bearing for home-based care too. And these are some data within the last 2 years. These are unpublished. We are in the process of publishing it. The outreach has been huge. You can reach good number of people. A large number of elderly people have been treated, majority of them females, and the satisfaction levels have been quite high. And more importantly, the risk factor control is pretty good as clinical trials. We're not using fancy drugs here. We're using very simple drugs, but despite that, we've got good control of blood sugar and blood pressure. So lastly, I'm coming to a bit of stargazing to reduce CVD burden. What are the research needs? I think we need to add more and more of qualitative research. We need to look at adaptive designs and demonstration projects. We need advances in statistical analysis, contextualization of research, particularly incorporating social determinants, and newer concepts in research where consumer voice is very important. We never talk to patients, or we never talk to communities in terms of designing our health intervention. And we are looking at some new concepts such as photo voice or discrete choice experiments or e-cohorts. We co-design these interventions with communities. And ultimately, we need to have true partnerships with our patients, and we need to reimagine the health system. So, for example, as a cardiologist, this is my favorite suite called Mysore Park. And as a cardiologist, when I think of this, I think it should be appropriately named as Mysore Plaque, because it directly goes and deposits on my coronary plaque. But when we talk to patients, show them the photos. I mean, this is in a different context. There's a very unhealthy food in India called 2-minute noodles. And when we talk to women, the key themes that come out is they're saying that it is democratic, it's easily available, it's less costly, it's consumed by all, it's accessible easily, it's very convenient. I go to work for 8 hours and travel 2 hours, take a bus and come back, and it takes 1 hour of travel for me. And when I come home, it's easy for me to cook this and give it to the kids. So this is what they think. You might say that it is bad, you should not consume it. But when this is the reality, how do you do it? So you need to look at these kind of approaches. The second is in terms of improving healthcare. We think that if we provide everything, things improve, but we need to look at the patient journey. So we are creating what are called e-cohorts, which are not registries, but they provide a detailed longitudinal picture of a patient's journey. It provides a patient's experience over the course of care from the first visit to follow-up care visit. It focuses on process of care and outcomes from the patient's perspective, provides patient-reported outcome measures and patient-reported experience measure. And we have embarked on this in terms of hypertension management in 2 cities of India. So these are some of the innovations that we require in terms of research. And ultimately, we need to reimagine the health system if we have to combat cardiovascular disease. And I think the solution would be an integrated, technology-enabled, patient-centered, high-impact, equitable health system intervention. And for that, community engagement and involvement is an important piece. They should be included in research from the time of the inception of the research program itself. So this is my final slide. If you have to reduce gaps in the prevention treatment, we need 4 things. And research has to be from multiple angles. One, we need scientific credibility. This comes from our basic biomedical and epidemiological research. We need to look at whether it's cost effective and affordable from health economics research. We need to look at operational stability, whether it can be scaled up, whether it's sustainable, and we require health systems research. And we need to look at the political viability of our findings. Will the community accept it? And we require social sciences research. And for this, we need what is called as a transdisciplinary approach, because it goes beyond the boundaries of our disciplines. And we need to work with multiple groups, economists, nutritionists, statisticians, policymakers, and so on, if we have to combat cardiovascular disease across the world. We need disruptive innovations, and we need attention to policy and upstream determinants. So I will leave you with these 2 quotes. As the African-American writer Toni Morrison in the book Song of Solomon said, if you don't create the future, the present extends itself. And my favorite poet, Robert Frost, who said 2 roads diverge in a wood, and I took one of those less traveled by, and that has made all the difference. Thank you very much.
Prabhakar, that was an amazing talk. A lot of food for thought. It's open for questions. Anybody, you can even put it in the chat if you don't want to ask. Prabhakar, maybe I can start. I think you actually concluded with this, and I was thinking as you were talking about this, that there's one thing that is the risk factors that cause cardiovascular disease, and really our training and the focus of physicians in general is to really take care of those. And we have better and better drugs to do that, et cetera. But on the other hand, you point out that there are a lot of these social pollution, many other environmental issues, even pre-birth issues that impact susceptibility that we really don't address. We actually don't measure. And or sometimes we are in this environment where we cannot even change it. And the people who are likely to be able to fix that is not the physician community, as you say, it's the policymaker. So, and you're doing wonderful work, especially in the field, to overcome some of these things in very novel ways. But how much of your time or people like you are spending with policymakers, pharmaceutical companies, and people like that who have the solutions, but as yet have not acted?
So I think that's a very tough question to answer, but you have to keep engaging with policymakers to multiple stakeholders. Actually, it's a long process. It takes time. You have to do it in a very unobtrusive manner. If you remember Otto von Bismarck, the Chancellor of Germany in the late part of the 19th century, he had a raging argument with Virchow, of the pathology fame, and he told him that there are 2 things you should not do in public. You should not see how sausages are made, and you should not see how policy making is done. So I think it has to be a little unobtrusive. It is a slow process. In fact, creating a national program for cardiovascular disease and prevention in India, it took almost 15 years with a lot of advocacy, different stakeholders having different ideas. So it's a slow process, but it works. But I think one of the things that we need to do is we need to demonstrate with evidence and then go to policymakers. We shouldn't go with half-baked ideas, and that's where things get into trouble. Like, for example, even now, many policymakers dismissed air pollution as not a major issue. The reason for that is air pollution is difficult to measure. Exposure, it's not like hypertension or diabetes, where you have, in a longitudinal study, you have blood pressure at a particular time, and then moving forward, you have disease and you link them. Air pollution is dynamic, it's daily. How do you measure it? There are multiple ways of measuring it. And so you do modeling. So people go with half-baked models and say, okay, because of our model, we can show the relationship. And people say, no, it's not correct. So I think we have to be very, very diligent about our science. We have to pay the highest attention to the quality of science that we generate, and only then we can change policy. In terms of pharma, we have to talk their language and try and see and work together. Obviously, polypill has been a failure, so we are saying the government should invest in manufacturing polypill because it's so inexpensive. So those are some of the things.
Thank you.
There's a question in the chat box,
Yeah.
I think.
The question is, how do you mitigate acceptance impediments of lifestyle changes at individual level?
It's a tough call again, but can be done. I showed the example with the family-based intervention. So what is required is, like a lot of people say, that we provide information, we provide education to people to change their lifestyle and things will improve. But behavior change requires three things. First is the knowledge, so that the person can say, I know. Second is the confidence with which they can act. They need to be empowered so that they can say, I can. And the last is a desire to make that change so that they can say, I want. And for all of these three, we need to provide an enabling environment. You might ask people to walk, but there are cultural differences. Women may not be allowed to walk in a certain particular culture. So we need to overcome that. How do we do that is a question of research that we can do. Increasing fruit and vegetable intake, we say, is an important aspect, but fruit and vegetables are very expensive. We don't have these kitchen gardens. We don't have space to make these gardens. We have water depletion, which reduces the content of antioxidants in fruits and vegetables. There is 50% loss of fruits and vegetables during transport. Can the government give a tax break? So what's the role of our profession here? I think you require three E's. You require an energetic profession, an enlightened polity, and empowered community. And our profession has to be energetic. We are the most influential people in the community. When we talk, people listen. When we write, people read. So I think we should become activists. We should become lobbyists for change, and we should advocate with the government or advocate with whatever stakeholder that is required to make this change.
Other questions?
It's Stan Sherman. Has there been any good data about teaching in schools that it would make a difference if we really had a good health program in our schools?
So there are systematic reviews, largely from high-income countries and mainly from Canada, particularly in terms of obesity. Education itself does not make a change, but I think a combination of curricular change, it should be part of the curriculum, number one, and second, involvement of the local community and family. That is where they have shown major changes. Otherwise, most of the results have been neutral in terms of school programs.
All right, it's right on the hour at 8:30. Prabhakar, it was truly a pleasure and very informative, and I hope we can do this again very soon. And thank you very much.
Thank you. Thank you very much for listening to my talk.
The preceding program is copyrighted by Emory University.